Hi everyone, my name is Priyesh and I'm currently QUESMED's Digital Teaching Fellow. Today I'm going to give you a quick tour on how to get the most out of our platform. So once you've bought a subscription and you've entered the QBank platform, the easiest way to start doing a set of unseen questions is hitting our Quick Start button. Then you'll see that for each question we have detailed explanations on why each answer is correct or incorrect, and we also have a page associated with each question. This goes into depth on everything that you need to know for that condition. Next, I'd like to show you our flashcards, and these are based on an AI algorithm which takes into account the questions that you've got wrong and need to learn further to produce a daily set of flashcards which you can then rate to then further help determine what you need to see on the next day. And as I mentioned, these refresh every single day. We have mock tests on our platform as well, including prescribing assessments. And as mentioned, we have a detailed knowledge library, which is a textbook covering exactly what you need to know for your exam for each condition. For example, acute coronary syndrome, where we have a summary followed by all the important aspects of the condition, including references at the end. We also have videos which cover tutorials as well as lectures. And just to quickly show you, we also have an OSCE which will cover the practical elements of your exams, including A to E assessments, communication skills, examination stations, and history taking stations. So for example, with each and every station, we can take them under timed conditions, and this is something that you can do with your friends where you can each take up a role and you can practice and go through them together. And for each OSCE station, we also have a walkthrough on how to approach that station as well. So that's everything that I wanted to cover today. That was a whistle-stop tour. If you have any other questions, please email us at info@quesmed.com, and I hope you found that useful. Thank you for watching.
Hi everybody, my name is Alicia. Welcome to your third PSP lecture. Today, myself, Sophie and Alexa are going to be walking you through this lecture, which is on antenatal care and medical disorders in pregnancy. It'll go for about an hour. The structure of it is that we'll do an MCQ, a case, and then we're going to go through 5 key things that we think are important for each of the matrix topics we're covering today. This lecture is proudly sponsored by QUESMED, so thank you to them. These are the matrix items we're going to cover today. So there's quite a few, but as I said before, the structure is that we're doing a case or MCQ followed by key takeaways for each topic. So really just the essential things that we think are important for revising for each of these topics. And just a disclaimer, this is a student-created lecture series, so although we strive to make sure that it's as best as possible and there's no mistakes, we are humans and we are students, so there can be errors in these lectures. It's just important to note that, and if you do notice something, definitely message any of us or the MOGIG Facebook group, and we'll make sure we address it for next year. Alrighty, first question. A 25-year-old prima gravida attends a pregnancy assessment clinic due to swelling and headache at 35 weeks gestation. She has been antenatally well to date with all tests normal. Blood pressure is 150/100 and that's taken twice. She has 1 beat of clonus. Blood tests are normal and spot urine protein ratio is 0.06, with normal being less than 0.03. What is the most correct regarding her management? A, commence IV magnesium sulfate, then consider induction of labor. B, immediately conduct a CTG. C, commence an IV antihypertensives. D, commence IV antihypertensives for 2 hours and consider induction of labor. Or E, commence oral antihypertensives and follow up closely. So just let you have a think about what it could be. So the answer to this one is E, and I'm just going to quickly run you through why it's E. So first of all, A, it's not A because IV mag sulfate is indicated in eclampsia. What this stem is trying to tell you is that this patient has preeclampsia. So IV mag sulfate is only indicated in eclampsia. Immediately conduct a CTG. That's not a bad thing to do, but it's not the most appropriate answer for this scenario. Commence on IV antihypertensives. Again, this is preeclampsia. IV antihypertensives indicated in eclampsia. Commence IV antihypertensives and then consider induction of labor. IV antihypertensives, no. It's, well, again, this scenario is talking about preeclampsia. IV antihypertensives, the only role they play is in eclampsia. And then induction of labor, 35 weeks gestation. For preeclampsia, we consider induction of labor at 37 weeks for delivery. So that leaves us to our last one, commence oral antihypertensives and follow up closely. That's the most correct answer. And as I've written down there, in real life, you'd also want to admit them to the hospital, make sure they're stable, and then we would aim for delivery at 37 weeks gestation. So looking at antenatal schedule, it's an R1 condition. It's not titled antenatal schedule. I think it's antenatal care, something like that. So it is a really big topic. However, I don't think there's actually a lot that you get tested on in the exam setting from my experience. Main thing is with this antenatal investigation timeline, it is important that you have a rough idea. You don't need to know, what happens every single week, but things about having a booking visit, then you do your dating ultrasound, your 12 to 13 week scan. What does that involve? It's the morphology scan. When do you do your Aneuploidy screening? When do you do what happens at your 20-week scan? And then 26 to 28 weeks gestation, it's important to know these key things happen then. And then at 36 weeks, your GBS swab. I put a link here to a more comprehensive, detailed summary if you are wanting to know the detailed timeline of your antenatal schedule. So that link's just here. But if you're, really trying to revise last minute, these are the key things I think it's important to remember, particularly when you do your glucose tolerance test and your GBS swab. I think they're two key really things to be aware of. The next thing that's important under this R1 condition are booking visit bloods. So you have to be able to reel these off, particularly in an OSCE setting. The way I remembered it, it was 6 things. So it'd be the HCG, and then number 2, your blood one, so your FBE, ferritin, hemoglobin, electrophoresis. So you're screening for uremia, Haemoglobinopathies. 3, this is blood group, research status and antibody screen. 4, viral serology. So this is easy to think 6 total to remember, and then 6 for viruses. So Hep B, C, HIV, rubella, varicella, and syphilis, 6 in total. Blood glucose 5, midstream urine 6. And then, these extra ones only if indicated. So first pass urine of less than 25 years of age, and then plus minus vitamin D thyroid function tests. So the next thing is important to be able to calculate the expected date of delivery. So I've just written that clearly here. I think, first thing you have to ask is if they know when their last menstrual period was, and is a menstruation regular. If it is regular, then you go down this pathway, and it kind of breaks it up into, it was the ultrasound performed before 14 weeks, or was the ultrasound performed 14 to 18 weeks, and then depending on when that ultrasound was performed, you do something different. But then if you have an uncertain last menstrual period or a menstruation is irregular, you're always going to use the ultrasound estimate. Something that you might have come across is Naegele's rule. So this one is specifically referring to this first branch, as in they know when their last menstrual period was, and secondly, the menstruation is regular. So you're going down this branch. Then ultrasound is performed between 14 to 18 weeks. Okay. Now we're at the next thing we ask is, okay, do the dates differ less than or equal to 7 days? If they do differ less than or equal to 7 days, you use your last menstrual period estimate. And then you might be like, okay, we can do that, but how do you calculate that? This is referring to Nightingale's rule. So it's very simply, it's just subtracting 3 months, add 7 days, and then plus 1 year. So, if your last menstrual period was, I don't know, July 7th, you subtract 3 months, add 7 days, and plus 1 year, and that's your estimated date of delivery based on your last menstrual period. So that's all written down here. I know I went through that quickly, but we're trying to keep things very succinct in this lecture. The next thing that I think is important to know is know your medical disorders in pregnancy, which is a lot of different matrix topics that are covered in a different PSP lecture, but you have to know them specifically and how do they change with this antenatal schedule. So for example, if someone's rhesus negative, well, what does that mean? It means at 26 or 28 weeks, if they're rhesus negative, you're giving them anti-D at 26 and 34 weeks. So kind of being able to know, okay, for this medical disorder, how does that affect my antenatal schedule? And finally, I've popped this here. It's not really high yield, but antenatal supplementation, what things are recommended. 3 things to remember: folic acid 500 micrograms, iodine 150 micrograms, and vitamin D 400 international units. So that's your antenatal schedule, 5 things that I think are the key things to remember. Next question or next case. So we've got a couple. They are both beta thalassemia carriers and hence have significant risk of having a baby with beta thalassemia major. So this couple wish to have definitive testing as early in pregnancy as is reasonable. Which test would be most appropriate? A, amniocentesis at 11 weeks. B, combined first trimester maternal serum screen and nuchal translucency. C, non-invasive RPT at 10 weeks. D, chorionic villus sampling at 11 weeks. Or E, second trimester maternal serum screening. So the answer to this one is D. Key thing being here is reading the question and saying, okay, they want to have definitive testing, not screening. They want a definitive testing for this beta thalassemia. So knowing that it's definitive, it immediately rules out our screening, which is B and C and E, all screening. So then we're only deciding out of amniocentesis and chorionic villus sampling. A is wrong because amniocentesis is the one that's only available after 15 weeks gestation. Righty, so that leads us on to the next matrix topic. So antenatal screening, another R1 condition. This one's pretty big, and the topics I'm covering in this first section, they are quite interwoven in terms of antenatal schedule, antenatal screening, and all these things. They are very much interwoven. So it's good to make sure you know your basics with this because it does come up a little bit across different matrix conditions. All right, so things that I think are important with antenatal screening. For each of these conditions below, I think it's really important that you know, 1, how to screen for it, and 2, when to screen for it, as in when in your antenatal schedule is it being screened. So first one, we've got preeclampsia, and with that you also have to consider gestational hypertension. Just reading, preeclampsia, the definition, very basically what it is here. Importantly, it's hypertension recorded after 20 weeks gestation. That's a really key thing on 2 separate occasions, plus evidence of end organ dysfunction, which involves a whole list of things. Next condition is really important to be aware of is your diabetes versus your gestational diabetes. So when do you screen for this? Blood sugar level at your booking visit, and then glucose tolerance test at 26 to 28 weeks. And what the glucose tolerance test is, you have 75 grams of glucose in a drink, you drink that, and then you get your blood sugar done, at 0 hours, 1 hour, and 2 hours. And that's that test very basically. Your next thing that's important, next set of conditions that are important to consider with antenatal screening is anemia, as well as prevention of rhesus isoimmunization. So how do you screen for anemia? FBE ferritin, obviously, thalassemia, HB electrophoresis, and then based on that finding, plus minus DNA analysis. These set of things happen at the booking visit. And then for men at booking and at 28 weeks gestation, it's important to consider this next set. So you get your blood group, your rhesus status, and antibody screen. So this is screening for the rhesus type and preventing rhesus isoimmunization. Importantly, you do this group of tests again at 28 weeks in rhesus negative individuals. So that's a differentiation to be aware of. Your next set is your viral screening. So 6 things, like I said before, to think about with viruses: Hep B, Hep C, HIV. That's the first 3. Those 3 you get screened at your booking, as well as at 28 weeks for high risk women, such as with an IV history of an IV drug user. And then 4, 5, 6 is rubella, varicella, and syphilis. Only do that at your screening, at your booking visit. So the next one is just other things to be aware of: vitamin D, thyroid, and chlamydia/gonorrhea. But those ones you only screen for in women that are, at increased risk, or you think may be susceptible to certain conditions that would warrant you to screen for those things. So just a quick summary. I've just popped the investigations here. You have to know the timing, when do you do it, and then why you're doing it. So this group, blood group, rhesus status, antibody screen. As I said, booking in 28 weeks in rhesus negative women. And this is your why. For your FBE ferritin, HB electrophoresis, for the timing and why. Timing, it's just booking, and then anemia and thalassemia is what you're screening for. Next set, viral serology for rubella, varicella, and syphilis. When do you do it? And then why do you do it? When, it's just booking. Why, you've got the list of reasons there. And then thirdly, your last set of viral serology, Hep B, C, HIV, timing, and why. So hopefully you can just come back to that for revision if you're struggling with this stuff. Right, next question. Screening tests for Down syndrome offered to pregnant women rely on the measurement of a number of factors in order for an estimation of the risk that the pregnancy is affected by Down syndrome. Which of the following results in a low chance result? So choose a single best answer. A, beta HCG levels above average for gestation. B, AFP levels above the average for gestation. C, high maternal age. D, nuchal translucency above average for gestation. And E, previous history of Down syndrome. Apologies about the typo. B's not AFG, it should be AFP. So which one do you think of these results in a low chance result of Down syndrome? So hopefully you guys got AFP. And the reason for that is AFP levels above the average for gestation is a good thing. In Down syndrome, you actually get decreased levels of AFP. The other answers like beta HCG, high maternal age, all of these ones, they all increase the risk of the fetus having Down syndrome. So let's go through the next R1 condition. This is aneuploidy and anomaly screening. I think for this R1 set on the matrix, it's really important that you know the aneuploidy screening test always comes up. It's kind of a bread and butter thing. So very basically, you've got your combined first trimester screening. It is undertaken at about 12 weeks. Get your second trimester serum screening, as it makes sense. T2 starting, you do it at your second trimester. Then you got your NIPT. You can do that from 10 weeks. It's important to have a rough idea what is included in all of them, as well as what it tests for. So what I mean by that is, for this first one, the combined first trimester screening, it It does give you a risk estimate for T21, 18, and 13, but not neural tube defects. But your second trimester screening does give you a risk estimate for neural tube defects. It's also important to know what they're made up of. So particularly this second trimester serum screening, it's a quadruple blood test. Know that it's made out of the AFP, free HCG, the estriol, and inhibin. Okay, so you need to know that one. And then like diagnostic tests. So if you've got, ends up being, you know, a high risk of, for example, Down syndrome, what do? You've got two options to give you a diagnostic test. And, you know, you do a diagnostic test, but it's important to firstly have a discussion with the family, because they always, if they're gonna want a child even with Down syndrome, then why would you go through a diagnostic test when there's a risk of miscarriage? So yeah, do your Aneuploidy screening test, discussion with the family, consider the appropriateness of diagnostic test, and if it is going to change management, this is when you do your diagnostic test. Very simply, chorionic villus sampling is available 11 to 13 weeks, and amniocentesis 15 to 18. Know those key dates. And then this is probably like just another level above, but it does come up. It's about how Down syndrome affects your screening blood test. So I've written it really clearly here, but for your combined first trimester screening, you get a decrease in Papa A. So decrease in Papa A is associated with increased risk of Down syndrome. Increase in beta HCG, that's like a marker of increased risk of Down syndrome. And then I've also listed them here for the second trimester serum screening. Although they're annoying to remember because they always like changes where they go up and down, it does come up. Next thing to be aware of, nuchal translucency thickness greater than 3.5 millimeters is associated with cardiac and abnormalities and congenital defects. And then this is probably a bit more peds, but you do need to know differences in presentations for T21 versus T18 versus T13. So your Down syndrome, your Edwards and Fetal's, you need to know the differences in how they present. I've just put this really blurry diagram here just to really clearly demonstrate the differences between all of the screening options and what they actually involve and what they screen for. So it's just there for your reference. Okay, next case, we've got a 34-year-old G3P2 tends at 16 weeks gestation for pregnancy care. Her pregnancy investigations are normal except for the midstream urine, which cultures 10 times by 10 to the power of 10 to the power of 2, sorry. What is the best advice for this woman? So based on that result, what should this woman do? A, screen for GBS at 36 weeks. B, should be treated for oral penicillin, should be treated with oral penicillin now. C, should have IV benpen in labor. D, should be treated with oral cephalexin now. Or E, she should repeat the MSU specimen. Which one do you think is most appropriate? So this one's C. GBS management comes up a lot. We're going to talk about it very shortly, but yeah, the most relevant in terms of if someone has been, you know, you do screening at 36 weeks for GBS, but if they get GBS picked up in the midstream urine, you already know this woman's a carrier of GBS, or like with the vagina is colonized with GBS, so there's no point resobbing them at 36 weeks. So you know that they're positive, and then the management of someone who's GBS positive is this IV benpen in labor. I think it's relevant to know when not to perform a GBS swab in pregnancy. So firstly, any amount of GBS identified, such as midstream urine, having a baby previously infected with GBS, as well as if an elective C-section is planned, because, you know, I think there is this colonize the GBS of the anus and the vagina. So if you have a C-section and the baby's not going to be affected by that GBS if they're having, the C-section. So hopefully that one was pretty straightforward. GBS screening, it's not a whole lot to remember, but it's a very high yield topic. It comes up a lot. So firstly, GBS, or Streptococcus agalactiae, is the #1 cause of neonatal infection and sepsis in developed countries. As I said before, it occurs naturally in the vagina and anus, and it occurs in about 20% of women. Importantly, how do we screen for GBS? It's with a combined low vaginal and anal rectal swab at 36 weeks gestation. Fourthly, screening results are only valid for 5 weeks. That's really important for this screening. So when I say valid for 5 weeks, that's for this when you're screening with this GBS swab. It's not if they've got it picked up in their midstream urine. So if someone gets a positive result at 36 weeks and their pregnancy continues to 42 weeks, let's say, it's really important that anytime beyond 41 weeks, they have to actually get a re-swab done. Fifthly, it's important to know the management. So no treatment is recommended during pregnancy if someone's GBS positive, but as soon as labor starts or upon strumming, they have to come immediately to hospital where they get this IV Ben pen. And, I don't think you know doses, but it does change every year. So if you're someone that, really wants to be on it, I would recommend knowing these doses, 3 grams initially, then 1.8 grams IV for hourly until birth. And following birth, it's important that you also review the baby for the neonatal early onset sepsis. Alrighty. Next case, we've got a 37-year-old G3P2 presented with cramping pain and vaginal bleeding for the last 4 hours. HCG is positive. Pelvic ultrasound reveals an empty uterus with a 3 centimeter left adnexal mass, the fetal pole and heart rate detected. What is the next appropriate step? A, diagnostic laparoscopy. B, methotrexate 50 milligrams followed by misoprostol 800 micrograms. C, organizer suction DNC. D, repeat ultrasound in a week. Or E, salpingectomy. Which one do you think is most appropriate? So the answer to this one is a salpingectomy. Key things you have to remember is when you go through any case like this, it's really important that, okay, you have to consider, they've got cramping, bleeding. Well, first, are they pregnant? Yep, they've got a urine HCG that is positive. That tells me they're pregnant. The next thing we're considering is, do we know where this pregnancy is? Is it intrauterine or is it not intrauterine? Pelvic ultrasound reveals an empty uterus. Okay, it's not intrauterine with a 3 centimeter left adnexal mass. Okay, we've got a mass that, in the adnexa, and there's a fetal pole and heart rate detected. That immediately tells me that, there's a live fetus there, because the heart rate detected is the biggest giveaway. So we've got an ectopic pregnancy. In this instance, the only appropriate option will be the salpingectomy. You may have gotten tricked by doing a diagnostic laparoscopy, but the only relevant one here would be the salpingectomy, because we know what's going on based on this scan, and having a laparoscopy is not needed in this case. There's no indication for having a laparoscopy. So termination of pregnancy is the last R1 condition I'm going to be going through. Firstly, it's important to know, who's eligible to have a termination of pregnancy. The answer to that is everyone, but more specifically is anyone before 24 weeks gestation can have a termination of pregnancy, no questions asked. But if you're beyond 24 weeks gestation, you can still have a termination of pregnancy, but you do require 2 doctors to agree that it's appropriate. And this is under the Victorian legislation. So when we say agree it's appropriate, it's take into account their social circumstances, medical circumstances, psychological circumstances, very much a holistic picture. The next thing that's important is to actually know your medical and surgical management when you're managing a termination of pregnancy. So very simply, who's relevant for medical management, in uterine pregnancy up to 9 weeks gestation. It's a key date to remember. This is also key to remember, 200 micrograms of mifepristone, which is an anti-progesterone agent, key to remember. And 36 to 48 hours later, you have 800 micrograms of misoprostol, a prostaglandin analog, which the prostaglandin actually helps expel the contents. It's also important to remember the contraindications to medical management. It's a key thing that comes up quite a lot. Most of them are pretty straightforward, except ones you might get are a bit more curly. Long-term oral corticosteroid use and ED grade, like travel time to the emergency department is more than 2 hours. For surgical management, who's eligible in uterine pregnancy, it's usually between 6 to 14 weeks gestation. What does it involve? Involves dilation and suction curette under GA. If it's a second trimester surgical management, then that's very simply what it involves. You also do get given misoprostol as well with the surgical management, as well as antibiotics, but I don't think you need to know the key numbers there. Main thing is just, what does it involve? The suction, DNC. And then finally, know how, this is the thing that I think does throw you off in an exam setting if you don't know your stuff well. Know how termination of pregnancy management and contraindications to termination of pregnancy management differs from the management of miscarriage. So it's very similar medication, but the doses differ slightly between termination of pregnancy management and miscarriage management, and the contraindications to like medical management differ slightly between those two. So that's just important to keep at the back of your mind and just have really clear. So that finishes my part of the talk. I'm just now going to pass you on to Sophie. Again, if you have any questions, feel free to message, and I hope you guys found that useful. Best of luck with your exams. Just go through each matrix condition best you can, study with your mates, and go through all the practice questions. It's the best advice I can give you, and try and enjoy the process as well. It'll be over before you know it. Thanks.
Hi, my name is Sophie, and today I'll be taking you through fetal growth and well-being, fetal growth restriction, decreased fetal movements, hypertensive disorders in pregnancy, including preeclampsia, and hyperemesis gravidarum. So starting off with our question on fetal growth and well-being, we've got which of the following investigations in pregnancy is used to monitor and assess fetal growth? We have A, biophysical profile, B, cardiotocography, C, fetal biometry, D, umbilical artery Doppler, and E, middle cerebral artery Doppler. So the answer to this question is C, fetal biometry. Fetal biometry is also known as growth scans. They measure fetal growth, and specifically they measure the biparietal diameter, head circumference, abdominal circumference, and femur length. And using these measurements, we can calculate the estimated fetal weight. So a bit more onto the other types of scans. Our biophysical profile is used to assess fetal well-being in the 3rd trimester through 5 components: fetal breathing, fetal movements, fetal tone, amniotic fluid volume, which can also be reported as the amniotic fluid index, and a non-stress test or reactive fetal heart rate, so a CTG. Continuous observation must occur for at least 30 minutes during a biophysical profile before defining any variable as absent. This is due to the fetal sleep-wake cycles. Any abnormalities can imply significant fetal hypoxia at the time of testing. Cardiotocography, or a CTG, is a form of fetal surveillance used to monitor fetal well-being as well, but it looks specifically at uterine contractions and fetal heart rate using transducers placed on the maternal abdomen. Again, abnormalities may indicate fetal hypoxia. Fetal Doppler assessment measures flow and pulsatility index through the fetal umbilical artery or the fetal middle cerebral artery. Specifically, the pulsatility index, or PI, represents the difference in systolic and diastolic flow. This is indicative of resistance in flow. So the bigger the difference in the systolic and diastolic flow means that there's increased resistance and therefore a higher pulsatility index. Umbilical artery, or UA Doppler, assesses blood flow through the umbilical artery, allowing evaluation of the fetal-placental circulation. Decreased flow and increased pulsatility index with our UA Doppler is problematic because this indicates placental insufficiency. Our middle cerebral artery, or MCA Doppler, assesses blood flow through the middle cerebral artery, allowing evaluation of cerebral shunting. Increased flow and decreased pulsatility index is problematic with our MCA Doppler because this indicates cerebral shunting, or increased blood flow to the fetal brain, which occurs in fetal hypoxia. Onto our discussion on fetal growth restriction. Our question here is, Jane is a G0P1 woman at 28 weeks gestation. Recent investigations have revealed her baby's estimated weight is in the 5th centile. Umbilical artery Doppler ultrasonography was performed, revealing an elevated pulsatile index without absent or reversed end diastolic flow. Which is the most appropriate ongoing management? A. Weekly biophysical profile and fetal Doppler assessment, aiming for delivery around 38 to 39 weeks gestation. B. Twice weekly biophysical profile and fetal Doppler assessment, aiming for delivery around 37 weeks gestation. C is to perform a biophysical profile and fetal Doppler assessment every second day, aiming for delivery around 34 weeks gestation. And finally, D, a biophysical profile and fetal Doppler assessment performed daily, aiming for delivery around 32 weeks gestation. So the answer to this question is B, a biophysical profile and fetal Doppler assessment twice weekly, aiming for delivery around 37 weeks gestation. In terms of why this is the correct answer, when we have an umbilical artery Doppler that demonstrates an elevated pulsatile index, fetal surveillance should be performed twice per week, aiming for delivery around 37 weeks gestation, and this comes directly from prompt. Before we delve into the management of fetal growth restriction, let's define some terms. So firstly, small for gestational age, or SGA, refers to when the estimated fetal weight or fetal abdominal circumference is below the 10th percentile. This is a term that only defines growth, so a diagnosis of SGA doesn't necessarily imply pathology. It can be constitutional, so physiological rather than pathological. When we talk about severe SGA, that refers to estimated fetal weight or fetal abdominal circumference below the 3rd percentile. Fetal growth restriction, or intrauterine growth restriction, on the other hand, defines a small for gestational age fetus with poor well-being and a high risk of poor perinatal outcomes. So this is a term that defines both growth and well-being. It's often very difficult to distinguish between SGA and fetal growth restriction during pregnancy. So therefore, management pathways often consider the overall care rather than making a distinction between the two. So in terms of the management of intrauterine growth restriction, it's always important to have specialist care involvement. So this refers to obstetrician-led care with pediatric involvement. Fetal biometry, or our growth scans, should be performed every 2 weeks, and we need to have serial fetal surveillance, which includes a biophysical profile and fetal Doppler assessment. The frequency of our fetal surveillance and our aims for delivery dates depend on the outcomes of our Dopplers. So if our UA and MCA Dopplers are both normal and the estimated fetal weight is above the 3rd centile, fetal surveillance should occur weekly, aiming for delivery around 38 to 39 weeks gestation. If, on the other hand, the estimated fetal weight is below the 3rd centile, fetal surveillance should occur twice per week, aiming for delivery around 37 to 38 weeks gestation. If our umbilical artery Doppler demonstrates an elevated pulsatile index, fetal surveillance should occur twice per week, aiming for delivery around 37 weeks gestation, which was the case in this scenario. If our umbilical artery demonstrates absent end diastolic flow, fetal surveillance needs to increase to 3 to 4 times per week, aiming for delivery around 34 weeks gestation. And if our umbilical artery Doppler demonstrates reversed end diastolic flow, fetal surveillance should occur daily. This is very severe, and so delivery should be aimed for 32 weeks gestation. If our umbilical artery Doppler demonstrates reversed end diastolic flow, this is very high risk, so our fetal surveillance should occur daily, aiming for delivery around 32 weeks gestation. Finally, if you ever see an abnormal ductus venosus Doppler, delivery should be expedited regardless of gestation. On to decreased fetal movements. So our question in this case is, Mary is a G1P2 woman who has presented to the pregnancy assessment unit at 36 weeks gestation with decreased fetal movements occurring over the past 4 hours. Her medical history has been taken and a physical examination performed. What is the next most appropriate step? A, we have auscultate for fetal heart rate with a handheld Doppler. B, apply a CTG. C, perform an abdominal ultrasound. D, refer for biophysical profile and Doppler assessment. Or E, emergency delivery via cesarean section. The answer to this question is A, auscultate for fetal heart rate with a handheld Doppler. Just remember that whenever you have a pregnant patient presenting with decreased fetal movements, the first step is always to auscultate for fetal heart rate with a handheld Doppler, and that's before you progress on to any other steps. So a brief background on fetal movements. They're felt by the pregnant person and usually begin around 20 weeks gestation, and they steadily increase in strength and organization throughout the pregnancy, becoming more structured as the pregnancy progresses. The movements incorporate sleep-wake cycles of 20 to 40-minute duration throughout the day and night, and every pregnant person experiences fetal movements differently, describing them from kicks to flutters or from swishes to rolls. And given this variety of maternal perception of fetal movement, it's not really possible to agree on a correct number of kicks to indicate a healthy pregnancy. So therefore, understanding a baby's own unique movements is really important to helping recognize any changes. Importantly, decreased fetal movements are often a precursor to adverse perinatal outcomes, including stillbirth. So whenever a pregnant patient reports decreased fetal movements, it's really important to assess both the patient and the fetus as soon as possible, and this usually occurs within the pregnancy assessment unit. Pregnant patients should be firstly assessed for risk factors for intrauterine growth restriction, and the symphyseal fundal height should be measured. Then the fetal heart rate should be auscultated with a handheld Doppler. If you can hear fetal heart activity with that handheld Doppler, you can progress onto the CTG, but if it isn't heard, we need to arrange for an ultrasound. If we note that fetal heart activity is present on the ultrasound, we can proceed to a CTG, but if it isn't present, we need to manage this as fetal death in utero. After applying a CTG, you can kind of classify it into 3 main outcomes. So firstly, if the CTG is normal and the pregnant patient is now feeling normal fetal movements, you can consider fetal biometry and a biophysical profile, otherwise discharge. If the CTG is normal, but the pregnant patient is still not feeling normal fetal movements, you need to organize fetal biometry, biophysical profile, and Doppler assessment within 24 hours. If the CTG is abnormal, care should be escalated to a senior obstetrician with consideration of delivery via emergency cesarean section. On to hypertensive disorders in pregnancy. Our scenario is a 29-year-old G3P2 woman is induced at 38 weeks for pre-pregnancy hypertension. Her blood pressure is 150 on 100 after oral medication and early active labor, with 3 contractions every 10 minutes. Her platelet count is 250, which is in the normal range. That was taken 2 hours prior. Other preeclampsia investigations are normal. She's had vaginal births previously. Select the appropriate step in management. A, arrange a code green or category 1 cesarean section. B, seize the oxytocin infusion. C, commence a magnesium sulfate infusion. D, commence an intravenous antihypertensive. Or E, recommend epidural analgesia. And the answer to this question is E, recommend epidural analgesia. The reason behind this is because for non-severe hypertension in labor, so blood pressure below 160 on 110, epidural can be considered as an intervention to reduce blood pressure. Other important points to remember for the intrapartum management of hypertensive disorders is that continuous CTG monitoring is always required, and ergometrin, including symptometrin, is contraindicated for active third stage management. So onto a bit of background and definitions. First up, we have chronic hypertension, which refers to hypertension diagnosed prior to pregnancy or with onset before 20 weeks gestation. We also have gestational hypertension, which refers to hypertension with onset after 20 weeks gestation. Preeclampsia refers to hypertension with onset after 20 weeks gestation, with evidence of end organ dysfunction, which can involve the kidneys, which is most common, the liver, the placenta, or the brain. Eclampsia refers to a severe manifestation of these hypertensive pregnancy disorders, and it's characterized by new onset eclamptic seizures, which are tonic-clonic seizures. The onset of eclamptic seizures is usually intrapartum or postpartum, and it's most often associated with severe preeclampsia. The warning signs of eclamptic seizures include deterioration with headaches, visual disturbances, hyperreflexia, clonus, and nausea and vomiting. In terms of the investigations for hypertensive disorders in pregnancy, it's important to measure blood pressure and assess for symptoms of preeclampsia, so headache, visual disturbances, and edema at each antenatal visit. If we find that the pregnant patient's blood pressure is above 140/90 or they're symptomatic, we should perform a urine dipstick to exclude proteinuria. And if we note that proteinuria is present, we should perform a spot urine protein to creatinine ratio, or UPCR. And in this case, if we have significant proteinuria, so above 30 milligrams per millimole, that's suggestive of preeclampsia. We should also perform preeclampsia bloods. So that includes an FBE to exclude anemia and infection, UEC and LFTs to exclude renal and hepatic impairment, uric acid to exclude hyperuricemia. So raised uric acid is strongly associated with the development of preeclampsia. And if our LFTs are abnormal or thrombocytopenia is present, we should also perform coags to exclude coagulopathy. So in terms of the management principles for all hypertensive disorders in pregnancy, we should have specialist care involvement, so obstetrician-led care with pediatric involvement. Importantly, our target blood pressure is below 140/90. So if our blood pressure is above 140/90, which is mild to moderate hypertension, we should implement stepwise pharmacological treatment. So starting with oral labetalol, oral methodopa, oral nifedipine extended release, and finally oral hydralazine. If our blood pressure is above 160/110, this is severe hypertension, and at this point it's very important to admit the patient under obstetrics, insert 2 wide-bore intravenous cannulas, and implement stepwise pharmacological treatment, starting with oral nifedipine, IV labetalol, and IV hydralazine. We also need to make sure we're monitoring this patient, so performing a continuous CTG, maternal observations, so our vital signs every 15 to 30 minutes, and inserting an indwelling catheter with a burette to measure urine output. Specific management for chronic hypertension or gestational hypertension includes assessing for proteinuria via urine dipstick at each antenatal visit, performing preeclampsia bloods if we note an acute increase in blood pressure or new proteinuria, and performing fetal biometry and fetal Doppler assessment alongside an amniotic fluid index at 28 weeks gestation, repeating as indicated in chronic hypertension, and at diagnosis, repeating every 4 weeks for gestational hypertension. For management of preeclampsia, the patient should present for weekly antenatal clinic appointments with weekly preeclampsia bloods. We should also perform our growth scan, so fetal biometry, every 2 weeks, and arrange for a biophysical profile, fetal Doppler assessment, and amniotic fluid index every week. Delivery should also occur by 37 weeks gestation in preeclampsia. Magnesium sulfate is something that's really important to keep in mind for eclampsia prevention, and it should be initiated in the presence of neurological symptoms, so severe headache, visual disturbances, hyperreflexia and clonus, and in severe preeclampsia, which includes having a blood pressure that is above 160/110 that's refractory to treatment, and in worsening renal or hepatic function. Onto our last topic, which is hyperemesis gravidarum. Our question is, which of the following is not a recommended strategy for the management of hyperemesis gravidarum? A, we have oral doxylamine and oral vitamin B6, otherwise known as paroxetine. B, intravenous fluids and electrolyte replacement. C, small frequent meals and dietary modifications. D, thiamine supplementation. Or E, daily progesterone therapy. And the correct answer in this case is daily progesterone therapy. This is not a recommended strategy for the management of hyperemesis gravidarum. So again, a little bit of background. Nausea and vomiting in pregnancy is also known as morning sickness, but specifically hyperemesis gravidarum refers to the persistent, severe nausea and vomiting in pregnancy with onset in the first trimester. The etiology behind this is multifactorial, but it's often due to high beta-HCG levels. The timeline of hyperemesis and morning sickness more broadly, the onset is typically between 4 to 7 weeks gestation, with peak typically by 9 weeks gestation, and it usually resolves by 20 weeks gestation. However, hyperemesis may persist throughout the entire pregnancy. In regard to outpatient management, number 1 is dietary changes. So having small, frequent, high carbohydrate and low fat meals, particularly avoiding spicy foods and foods with strong flavors and odors is really important. Also using oral antiemetics. So first line is oral doxylamine with oral paroxetine, so vitamin B6. But we can also trial oral metoclopramide, ondansetron, prochlorperazine, and promethazine. It's important to be on the lookout for indications for hospitalization, and these include having a severe electrolyte imbalance or renal impairment, an inability to tolerate oral fluid or food intake or oral antiemetics, ketonuria or weight loss greater than 5% of body weight, and clinically significant dehydration that requires IV fluids. So on that point, in terms of the inpatient management, this includes parenteral antiemetics, most frequently IM or IV metoclopramide, but can also involve IV ondansetron or IM or IV prochlorperazine as well, IV fluid rehydration with electrolyte replacement as required, thiamine or vitamin B1 to prevent Wernicke's encephalopathy, and corticosteroid therapy. So usually IV hydrocortisone until clinical improvement, then we can wean to oral prednisolone. It's important to also consider thromboprophylaxis with low molecular weight heparin. That's all from me. Thank you so much for tuning in.
Okay, so the next question is, based on a 75-gram oral glucose tolerance test, or OGTT, which of the following blood glucose readings would result in the diagnosis of gestational diabetes mellitus? A fasting plasma glucose of 4.8 millimoles per liter. B, a fasting plasma glucose of 5.6 millimoles per liter. C, a plasma glucose after 1 hour of 5.6 millimoles per liter. D, a plasma glucose after 1 hour of 8.5 millimoles per liter. Or E, a plasma glucose after 2 hours of 7.8 millimoles per liter. Please pause if you'd like to think about the question, otherwise I'll move on to the answer and explanations. Okay, so the correct answer is B, which is a fasting plasma glucose of 5.6 millimoles per liter. Generally, I'd say that biochem thresholds don't need to be memorized, but it's certainly useful to have an idea of what's considered normal blood glucose parameters following an OGTT, that being approximately 5, 10, and 8.5 at fasting 1 hours and 2 hours, respectively. So, as gestational diabetes is an R1 condition, it is important to be very comfortable with screening, diagnosing, and managing it. So last year, one of our OSCE stations was on counseling for GDM. So here are 5 key takeaways that I will outline. Firstly, we've already discussed the diagnostic thresholds of 5.1, 10, and 8.5. And the key thing to keep in mind is that only one of these thresholds needs to be met for a diagnosis of GDM to be made. Secondly, all pregnant women should be screened for GDM with an OGTT at the 24 to 28 week mark. And women who are at higher risk, such as having previous GDM, obesity, or a family history of diabetes, might need earlier testing as well. When counseling on GDM, it's important to also understand the risks associated. I personally found it useful to think about it in terms of maternal and fetal risks in the ante, intra, and postpartum periods. So key examples include preeclampsia and macrosomia antenatally, and subsequently this also leads to an increased risk of cesarean delivery. After delivery, there's a risk of neonatal hypoglycemia and type 2 diabetes for both mother and baby. The fourth takeaway is that it's important to involve a multidisciplinary team in management, so get dietitians, diabetes nurse educators, and endocrinologists involved if needed, since management can include dietary changes, exercise, blood glucose monitoring, and then also possibly insulin therapy as well. And final takeaway, whether and when an early induction is offered depends on how well the gestational diabetes is controlled and whether insulin is being used for management. So if it's uncomplicated and managed on a diet and exercise alone, an early induction doesn't necessarily need to be offered. But for women whose gestational diabetes is managed on small doses of insulin, they should be counseled on delivering before 40 weeks to reduce the risk of stillbirth, infant mortality, and morbidity. If there are other concerns, including suboptimal blood glucose control, fetal growth restriction, then you might even consider planning delivery from 38 weeks or earlier. And the prompt guidelines for gestational diabetes testing and diabetes management are a great resource on this. Okay, next question. Which of the following is the most appropriate initial management for a pregnant woman who presents with an elevated serum thyroid stimulating hormone and decreased free T4 in her first trimester? Is it A, to increase dietary iodine intake, B, reassess TSH levels in 6 weeks, C, begin levothyroxine therapy with a starting dose of 100 micrograms daily, D, start methimazole therapy, or E, initiate thyroid function monitoring every 3 months without starting medication. Again, please pause if you'd like a moment to think about it. Otherwise, we'll move on. Okay, so the correct answer is C. In this case, we're looking at overt hypothyroidism, and so it must be treated with levothyroxine. Options B and E, which are basically monitoring and not commencing pharmacological intervention, wouldn't address the elevated TSH, and that's something that should be corrected in order to avoid adverse outcomes. Option A, looking at dietary iodine supplementation, or increasing dietary iodine intake, that's incorrect because whilst supplementing iodine is important for all pregnant women, in this case, it's not sufficient to manage overt hypothyroidism, where thyroid hormone replacement is required. And D is wrong because methimazole is used to treat hyperthyroidism and not hypothyroidism. Okay, so now in terms of key takeaways for this R2 condition, the first is regarding diagnosis and classification. Something to keep in mind about thyroid function during pregnancy is that the thyroid stimulating hormone TSH is structurally quite similar to the human chorionic gonadotropin, or HCG. And so HCG, which is elevated during pregnancy, has thyrotropic activity, resulting in a reciprocal decline of TSH during pregnancy. So during pregnancy, it is actually normal for TSH levels to be lower than what we might normally consider the lower limit of normal. And so there are trimester-specific reference ranges for TSH that should be used to enable the accurate detection of thyroid disease during pregnancy. In terms of screening, only targeted testing of TSH and free T4 is recommended for high-risk individuals, which might include those who have a personal history or type 1 diabetes. And in terms of classifying hypothyroidism, it can be considered overt, which is where TSH is elevated and free T4 is low, or subclinical, which is when TSH is elevated but T4 levels are normal. The second takeaway is regarding maternal and fetal risks. So untreated hypothyroidism in pregnancy is associated with risks such as preeclampsia, placental abruption, preterm birth, and developmental delays in the child. As we touched on earlier, this is also why daily iodine supplementation is recommended when planning pregnancy, and during breastfeeding as well, to support thyroid hormone production. Dietary intake of iodine is generally not sufficient for this, so that's why supplementation is important. In terms of management, levothyroxine should be used to correct elevated TSH levels in both overt and subclinical hypothyroidism. It's just that when it comes to overt hypothyroidism, the starting dose is higher, and dose adjustments should be made based on regular monitoring of TSH and free T4 levels. Final takeaway is if TSH is found to be abnormal, you should also refer the patient to the endocrine pregnancy unit and continue monitoring thyroid function approximately in 4 to 6 weeks. Okay, and again, prompt guideline is great for this. There's a Ranscock statement that was pretty useful as well. And in terms of better understanding the pathophysiology behind thyroid function in pregnancy, there's a really great RACGP article as well. Okay, next question. A 29-year-old pregnant woman of Southeast Asian descent is at her first prenatal visit. Her initial blood tests show a low mean corpuscular volume, MCV, of 78 and a low mean corpuscular hemoglobin of 26. She has no known family history of haemoglobinopathies. Her partner is also of Southeast Asian descent but has no abnormalities detected on thalassemia screening. What is the next appropriate step in managing this patient? Is it A, that no further testing is required? B, perform iron studies and consider iron supplementation? C, refer the patient for thalassemia DNA analysis? D, repeat full blood examination in the 3rd trimester? Or E, advise her partner to undergo a bone marrow biopsy? Pause if you would like. The correct answer is C. So refer the patient for thalassemia DNA analysis. The key thing here is that low MCV and MCH suggest a possible haemoglobinopathy, especially given the context of this patient's ethnic background. So we should do further testing and not delay further investigations until the 3rd trimester either. Doing thalassemia DNA analysis would help determine if the patient is a carrier of a haemoglobinopathy gene, which is crucial for determining prenatal care as well. Early diagnosis and management of haemoglobinopathies is important for avoiding complications, which we'll look at in a bit more detail on the next slide. And whilst iron deficiency is a common cause of microcytic anemia, our primary concern in a patient of Southeast Asian descent with a low MCV and MCH is ruling out any potential haemoglobinopathies. Okay. So as we touched on earlier, a key part of haemoglobinopathy management in pregnancy is early screening and diagnosis. The best time for screening is preconception, so that the most appropriate counselling and prenatal care can be provided. However, screening should be offered to all when pregnancy is confirmed as well. There's a very detailed testing algorithm available in the prompt guidelines on haemoglobinopathy screening, but in summary, partner testing should be done when there's an abnormal MCV and MCH or an abnormal hemoglobin electrophoresis result. If both in the couple are Southeast Asian and haven't previously been tested, then partner screening should also be offered. Further testing through DNA studies should also be done when there are those abnormal results in MCV, MCH, or electrophoresis, or when the partner has a known 2-gene deletion for alpha thalassemia. If both partners have abnormal blood results or unknown carriers, they should also be referred to genetic counselling. Further testing, including prenatal diagnosis, are crucial to assess the risk to the fetus. Prenatal diagnosis is only an option for couples when there is a risk of having a child affected by haemoglobinopathy and the causative mutations carried by the parents are known. Ideally, this is done pre-pregnancy because it is time-consuming. However, during pregnancy, diagnosis can be done during CVS or chorionic villus sampling during the 1st and 2nd trimesters. In the 2nd trimester, amniocentesis is also an option. Finally, comprehensive management is important, with the involvement of a multidisciplinary team, including maternal fetal medicine, hematology, and genetics. Pregnant women who are carriers of both alpha and beta thalassemia genes should take daily folic acid supplements starting 3 months prior to and during pregnancy. Iron supplementation should be avoided unless they also are iron deficient. Okay. Next question. A 28-year-old pregnant woman in her 1st trimester is seen in the antenatal clinic. Her recent blood work shows a low hemoglobin level and low ferritin level of 90 and 20. She reports feeling fatigued, lightheaded, and short of breath. What is the next best step in management? A. Recommend a high iron diet and continue routine prenatal care. B. Start oral iron supplementation and schedule follow-up blood work in 4 to 6 weeks. C. Refer to a hematologist for further evaluation. D. Administer an iron infusion immediately. Or E. Advise bed rest and monitor hemoglobin levels weekly. Pause if you'd like. Okay, and the answer is B. Start oral iron supplementation and schedule follow-up blood work in 4 to 6 weeks. So recommending a high iron diet and continuing routine prenatal care would be inappropriate because even though a high iron diet would be beneficial, this alone would be insufficient for treating iron deficiency anemia. And so with the current hemoglobin and ferritin levels that we're looking at, iron supplementation really should be commenced. Hematology referrals are generally reserved for cases where the anemia is not responsive to initial treatment, or where there's suspicion of an underlying condition, or it's a severe case that isn't manageable by oral iron alone. Likewise, iron infusions are typically reserved for more severe cases of iron deficiency anemia, or if there's intolerance or a poor response to oral supplementation. Also important to keep in mind that iron infusions are contraindicated in the 1st trimester, which is the case in this vignette as well. Okay. In terms of takeaways for iron deficiency anemia, much like with the haemoglobinopathies we discussed earlier, early screening and diagnosis is very important. So all pregnant women should be offered an FBE early in pregnancy to screen for anemia and iron deficiency. Repeat testing might be necessary at the 26 to 28 week mark, and also at 34 to 36 weeks, depending on clinical circumstances. In terms of management, the first-line treatment recommended is oral supplementation. So women who are diagnosed with iron deficiency anemia should have follow-up blood tests to monitor their response to treatment, typically around 4 to 6 weeks after starting supplementation. Iron deficiency anemia in pregnancy is quite common, and it affects about a quarter of pregnancies in developed countries. This is significant given the impact that it can have on both mother and baby. So iron deficiency anemia in pregnancy is associated with fatigue, reduced cognitive performance, and an increased risk of preterm birth, low birth weight, and small for gestational age infants, especially in severe anemia. So it's important to make sure that we're appropriately managing patients with iron deficiency anemia in pregnancy to minimize these risks and ensure both maternal and fetal well-being. Okay, now moving on to the final question. A 32-year-old G1P0 woman presents at 34 weeks of gestation with intense itching, particularly on her hands and soles of her feet. This itching worsens at night. She has no rash, but has noticed dark urine and pale stools. Her liver function tests and serum bile acids are elevated, and she has no history of liver disease. What is the most likely diagnosis? Is it A, pruritic urticarial papules and plaques of pregnancy, or PUPP? B, acute fatty liver of pregnancy? C, intrahepatic cholestasis of pregnancy, or ICP? D, gestational pemphigoid, or E, hyperemesis gravidarum? Pause if you'd like. Otherwise, moving on to the answer. The answer is C, intrahepatic cholestasis of pregnancy, or ICP. So ICP is characterized by pruritus without a rash, as we can see in this clinical vignette, particularly on the hands and soles of the feet. It's also associated with dark urine, pale stools, and elevated LFTs and serum bile acids, which fits this patient's presentation. None of the other options really align with this clinical vignette. So of note, options A and D, which are the PUPP and gestational pemphigoid, they typically present with characteristic rashes on the abdomen. Examples of what that might look like are on the slides, but the patient in this vignette didn't have a rash. Acute fatty liver of pregnancy would also present with nausea, vomiting, abdo pain, and jaundice, and it's also typically associated with more severe liver dysfunction, not just itching. Jaundice is pretty rare in cholestasis of pregnancy and generally indicates other causes. And finally, hyperemesis gravidarum is characterized by severe nausea and vomiting leading to dehydration and weight loss, not the pruritus or liver enzyme abnormalities that we're seeing in this case. Okay, so finally, some key takeaways about cholestasis of pregnancy, which is an R3 condition. Okay, so ICP is diagnosed most typically through clinical history lab findings, which, as we saw previously, included elevated LFTs and serum bile acids, and exclusion of other liver diseases. Pruritus without a rash, especially on the hands and soles of the feet, is a key symptom. Management is generally symptomatic, and pruritus might be relieved through topical emollients, antihistamines, and ursodeoxycholic acid. But recent evidence suggests that there might actually not be significant benefit in pruritus or pregnancy outcomes from ursodeoxycholic acid. If there is prolonged prothrombin time, you might also consider vitamin K. While the main maternal complications are intense itchiness and sleep deprivation, there are some pretty significant fetal risks associated with ICP. These include spontaneous preterm birth, iatrogenic preterm birth, mech aspiration, and fetal death. As such, ongoing maternal and fetal surveillance is crucial. Weekly monitoring of total bile acids and LFTs is recommended, as this also guides delivery planning. Fetal surveillance should start from 32 weeks gestation for those who have a bile acid concentration of 100 micromoles per litre or more, and the timing of birth also depends on these bile acid levels. So for bile acids below the threshold of 100 micromoles per litre, the risk of stillbirth is roughly similar to the general population, so delivery at term can be considered. For those with bile acids at or above that threshold, there is an elevated risk of stillbirth. And so earlier delivery at 35 to 36 weeks might be warranted after discussing the risks with the patient. Okay, now that brings us to the end of the third MOGIG PSP for the year. We hope you found it helpful. Thank you for tuning in, and thank you again to QUESMED for their generous sponsorship and support of our work. Don't forget to follow us on Instagram at mogig.monash and on Facebook as well to stay up to date with MOGIG events and academic resources. Thank you again for joining us, and we'll see you again in our next MOGIG PSP.